Hello dear friends and colleagues, today in this video named KYC, Know Your Culprit to Achieve Zero Endophthalmitis, we are going to discuss about most concerned pathogens for post-intraocular surgery infective endophthalmitis. Acute endophthalmitis can occur in 1 to 5 days post-op, subacute endophthalmitis can occur in 6 to 10 days post-op, whereas delayed endophthalmitis can occur 3 to 6 weeks later after the surgery or sometimes after months or years. Pathogens most responsible for acute endophthalmitis are gram-positive coagulase negative staphylococci, also known as CONS, Staphylococcus aureus, beta hemolyticus strains of streptococci, namely Streptococcus pneumoniae, Streptococcus mitis, Streptococcus salivarius, also gram-positive Enterococci faecalis and gram-negative Pseudomonas aeruginosa. Whereas for subacute and delayed endophthalmitis, the responsible pathogens are Propionibacterium acnes, Corynebacterium, Staphylococcus epidermis, and fungi, namely Fusarium, Aspergillus, and Candida. We will do KYC of each one of these in depth and details. Staphylococci are gram-positive, having single cell wall made of proteoglycans which take up violet of the gram stain. Their name comes from two Latin words. Staphylos means grapes, staphyloma means bunch of grapes, and coccus means round, ball or spherical. Remember, the coccus gives the name to coconut. The genus Staphylococcus is subdivided into coagulase negative or coagulase positive staphylococci. Coagulase negative staph are commensals of human skin and mucosa such as Staph epidermidis, Staph warneri, Staph capitis and Staph hominis, etc. Coagulase negative staph are usually slow growing, giving subacute endophthalmitis which begins on 6th to 10th day post-op. Almost no exotoxins or coagulase proteins are produced. They are less virulent. There is less fibrin and less hypopyon. Cornea and vitreous are usually clear. On B scan, the vitreous looks pretty much clear, just a very mild inflammation or mild haze. Anterior chamber also is clear, vitreous is also clear, so quite often we can even see the glow in these patients. Presenting vision usually is finger counting or hand movement, and the end result is very good, giving nearly 612 or 618 vision. So the visual prognosis of CONS endophthalmitis is usually pretty good. Coagulase positive staphylococcus of our concern is Staph aureus, which produces abundant exotoxins and coagulase enzymes. Staph aureus takes its name from aurum, which is gold in Latin. On a blood or nutrient agar, the Staph epidermis, the coagulase negative ones, will always produce white colonies in streaks or lines, whereas Staph aureus, the coagulase positive organism, they always produce golden yellow or lemon yellow colored colonies. When they infect the skin and the follicles, they produce yellow colored pus. Stye or mebominitis are caused by these coagulase positive Staph aureus, which produce yellow pus with significant inflammation signatures Ruber, Dollar and Keller. Anterior and posterior nasal cavity as well as roots of the eyelashes are the natural human habitats of Staph aureus. So the Staph aureus can come and lodge on surgical field from exposed lids and lashes of patients or from exposed nose and mouth of surgeons and or OT staff. By the way, exposed hair of surgeon and or OT staff and visitors can shed visible or invisible dandruff with which many microbes also fall, especially Malassezia fungus. These are very risky OT attire. Because coagulase positive Staph aureus produces so much of exotoxins and coagulase enzymes, the endophthalmitis caused by it is of faster onset, which is much more virulent. Vitreous involvement is significant, periocular and orbital tissues are inflamed, and lid edema and pain are very significant. Cornea is hazy and edematous, the aqueous is flared, iris details are not visible, hypopyon is more and more cheesy, typically yellow or golden yellow in color, presenting vision is hand movements or PL, visual prognosis is poorer, visual acuity even after full treatment is usually only PL plus or in finger counting. Significant posterior uveitis, vitritis with septa formation, and retinitis is seen on B scan. Retrobulbar soft tissues are also inflamed as seen on B scan, and usually this is associated with significant retinal necrosis. Significant retinal damage is the cause of profound vision loss even after the anatomical recovery. This is the comparative B scan showing the vitreous damage difference between the coagulase positive Staph aureus endophthalmitis versus the coagulase negative Staph epidermidis endophthalmitis. Gram positive streptococci are the next concern of ours. They are also known as strep-backed by the microbiologists. Streptococci take their name from two Latin words, streptos meaning string or chain of pearls or beads or glass beads, whereas coccus, as we know, is round, ball or spherical, and the coconut takes the name from this. Streptococci, they grow as white streaks or as scattered white colonies on blood agar. On the blood agar, which is containing 5% sheep blood in the base nutrient agar, beta hemolytic streptococci release extensive exotoxins named hemolysins, which will melt the red blood cells, converting them into serum or bile-like pigments. So the colonies make red agar underneath it into a yellow one and will also have a sizable and big yellow zone around. In alpha hemolysis, grayish green zone is produced, whereas in gamma hemolysis, practically very minimal hemolysis is produced. Thus, the hemolysis is the indicator of the exotoxinous activity of the Streptococcus genus. Streptococci of our concern are beta hemolytic streptococci, namely the Streptococcus pneumoniae, Streptosalivary and Streptometis. They are commensals of human skin, oral and nasal cavity and private parts. They are fast growing, very virulent and very high exotoxin producing. Dental caries and gum infections are caused by Streptococcus mitis, and haliotic and foul smelling mouths can also harbor abundant amount of Streptococcus salivarius. This is how the Streptococcus salivarius and Streptococcus mitis look under electron microscope. Streptococcus pneumoniae is commensal of mucosa of human upper respiratory tract. Coughing and sneezing, especially without proper type and position of mask of the face of staff or patients or relatives or doctors, can shed these bacteria in OT air as well as on the surgical field. Beta hemolytic streptococci endophthalmitis usually are very severe and very virulent. Vitreous cavity is highly infiltrated and highly inflamed. Presenting vision is very poor and visual prognosis is also very poor. In general, eyeball will be saved without any functional vision. Poor mask discipline of surgeon, OT staff and patients, having food or tobacco, pan, gudka etc. in mouth, leading to increased salivary secretions which can lead to more number of micro droplets shedding, talking too much or too loud, shouting in OT, sneezing or coughing in OT, mask below the nose or mask below the mouth. All these are the high risk factors for shedding the beta hemolytic streptococci from the mouth. These are the best way to shed these streptococci onto the surgical field. That is why triple layer surgical mask or better N95 mask completely covering nose and mouth of everyone, yes, everyone in the OT is absolutely essential. Now the gram-negative bacteria of our concern causing endophthalmitis is known as Pseudomonas aeruginosa. Pseudomonas gets its name from two Latin words, Pseudomonas and aeruginosa. It looks alike of a Micromonas micros, which is a marine or wild and domestic animals pathogen bacteria, which has one or more tails known as flagella. This is the electron micrograph of the Micromonas micros. This is Pseudomonas, so the name pseudo and monas is because it resembles or it looks but it is not the Micromonas. The word aeruginosa comes from the word aeruga, which means the verdigris, which is a copper oxide mixed with copper sulfate, which we usually see on the statues which are made of bronze or the roof which are made of copper. Because they always produce verdigris or aeruga color on nutrient agar, Pseudomonas are also known as P. pyocynia or Pseudomonas pyocynia because pyo means pus and cyan means blue because they produce the blue color pus. Most often, the Pseudomonas produces bluish or green colored lesions. It is a gram-negative flagellate and ciliated bacilli rods, aerobic as well as facultative anaerobic. It is abundant in dust and soil. It is very fast growing. It has very high levels of exotoxin production. Facultative anaerobe means they can respirate, survive and thrive in presence or in absence of oxygen. They can survive on carbon dioxide or carbon monoxide also. They don't want to die easily. Their survival instinct sometimes is more than ours. P. aeruginosa endophthalmitis are usually very virulent infections, often producing yellowish green or bluish green thick cheesy pus, which is so sticky that it will not change position even when patient sleeps flat or supine, or even when he sleeps on the side. The entire posterior segment as well as the retrobulbar tissues are so heavily inflamed that in spite of every possible treatment and every measure taken, the eye usually ends up as phthisis bulbi. Primarily, they are soil and dust bacteria which can enter in OT with soiled or dusty feet or hand of patients as well as staff. They can lodge on the OT table surface. They can grow on silicon dioxide and soil salts with humidity. Pseudomonas can survive on dust as their food and can colonize the air conditioner's fins, which has dark environment, which is cool and full of humidity and condensed water. So this jelly is the nutrient agar and the AC fins are the petri dishes for them. Sticky doormats can reduce the dust entering into the OT, and repeated OT table surface disinfection is essential to prevent the colonization of Pseudomonas. UV lights, even in operation theaters which are having HEPA filter and laminar airflow, are still essential. Enterobacter fecalis is another pathogen of our concern, which is a gram-positive gut commensal of humans forming chains. They produce abundant protease enzymes as exotoxin. This is how the Enterococci fecalis they look. Surgeons, staff nurses or paramedics as well as patients having long and dirty nails can harbor these gut bacteria in their nails. Especially in India, where for majority of the people after toilet visit washing the butt is done by the left hand. Even in Western world, using toilet papers and children or adult diapers are not safe from Enterococci fecalis colonization under the nails. Most people don't care to clean the underside of these long nails with disinfectants. Most often they smell the putrefaction of the Enterococci. In Enterococci fecalis endo, the visual outcome is very poor. Many eyes may undergo phthisis bulbi. Overall virulence of this infection in the anterior segment as well as the entire posterior segment and retrobulbar space is very high. Late onset, delayed or subacute or chronic endophthalmitis are usually caused by Propionibacterium P. acnes or Corynebacterium species or Staphylococcus epidermidis or fungi namely Candida, Aspergillus or Fusarium. Propionibacterium acnes is a gram-positive bacilli in the shape of rods, which is a human skin commensal. It produces propionic acid as its metabolic waste, which is its exotoxin, and hence the name, which are dormant or slow-growing microbes. P. acnes endo is almost always late onset, low in virulence, mostly confined to anterior segment, most often showing mutton fat capes-like deposits on endothelial surface of the cornea. Remember, poppy seeds-like picture is P. acne, P for pea. It is a cuscus-like deposits on the back surface of cornea or on the front and back surface of the IOL. Posterior segment is quite quiet. After the treatment in these cases, the visual regain is very good. This is a case of P. acnes endophthalmitis which occurred 21 years after the cataract surgery after doing the YAG capsulotomy. The next pathogen of our concern is non-diphtheretic Corynebacterium species, which is a gram-positive bacilli or cocobacilli. They are highly active in toxin production. They can form true or pseudomembranes. They are relatively less common cause of endophthalmitis, but if it occurs, it can cause devastating infection. Visual prognosis is highly variable. Fungi are another pathogens of our concern for endophthalmitis, especially Candida species, Fusarium species, and Aspergillus species. The overall incidence of fungal endophthalmitis in the world is 1%, but in India it is around 8%. Aspergillus is a sporulating and branching vesicle bulb forming organisms which could be white, black or green fungus, and it is abundant in indoor air. Aspergillus can grow wherever it gets starch or sugar as food, on corn, fruits, bread or potatoes. On leather items and cotton clothes, they can survive and thrive on cellulose as food. They can grow on walls, ceilings as well as false ceilings. They keep shedding and releasing their spores known as conidia. This is a typical picture of Aspergillus endophthalmitis. Another fungus of our concern is Fusarium, having spores in soil, airborne dust, plants as well as raw wood. Fusarium endophthalmitis begins late but begins very fast, and it is as devastating as Staphylococcus aureus. Hypopyon with fungal hyphates can be very easily seen in Fusarium growth. Another fungus of our concern is Candida species, which technically and actually is a yeast which is non-chain forming ovoids. Candida infections are usually white and less virulent. Tongue and the oral cavity are the natural habitats of Candida. So here again mask discipline as well as minimal talking and no shouting discipline is essential in the operation theatres. I repeat, this is a contraindicated and a very risky attire in the operation theatre. To summarize, fast-growing microbes produce high volumes and types of exotoxins. Even when they are killed by antibiotics, they release vast amounts of endotoxins. These toxins lead to severe inflammation. If the posterior chamber involvement is severe, visual outcome is very poor. If too much toxins are there, eye will go into phthisis bulbi. If we learn and know well the KYC of our pathogens just by looking at the clinical picture and history, we can come to a good provisional diagnosis of type of endophthalmitis even before the lab reports, even before any intervention. And also we can know and inform the visual and overall prognosis to patient and relatives. No matter how much and what we do for asepsis, some unwanted gas will enter the eye, if not in all, at least in about half of the cases. So we have to kill them before they kill the eye. In this section, let us discuss the difference between TAS and endophthalmitis, because at times the picture is quite confusing. TAS was previously known as sterile endophthalmitis, which was renamed as toxic anterior segment syndrome in 2005 by the ASCRS. TAS is caused by acidic, that is low pH, or alkaline, that is high pH, unwanted organic or inorganic chemicals entering the anterior chamber inadvertently during the intraocular surgery. TAS can also be caused by heat-stable exotoxins or pyrogens produced by the large amounts of microbes present in raw BSS or ring electrode before it is sterilized in the factory. These biochemicals may be now sterile but are still toxic, or by the endotoxins released by the dead and disintegrating microbes which are killed by the sterilization. BSS or ring electrode, which we use in AC infusion, or the normal saline or water for injection, which holds the hydrophilic IOLs and some hydrophobic IOLs in its blister or bottle packing, if these had high level of bacterial or fungal contamination while packing, the microbes have produced these toxins in abundant amount. So although these solutions may be sterile, but if they are not chemically inert, then they can induce TAS. TAS is a reaction to synthetic or biochemicals, whereas endophthalmitis is immune response to bacterial or fungal infection. It is almost immediate, occurring within 4 to 12 hours because there is no incubation period, whereas there is a certain minimum incubation period, usually 3 to 7 days, depending on the organism involved in endophthalmitis. TAS is limited to anterior chamber and at the most posterior chamber only, Posterior segment is unaffected and quiet, whereas in endophthalmitis, inflammation of the vitreous cavity, middle and posterior uvea as well as retina is almost always there. We can mentally compare TAS to food poisoning, which is a toxic response, whereas endophthalmitis can be mentally compared to cholera or dysentery, which is an infection. TAS is more of fibrin response, whereas endophthalmitis is fibrin as well as cellular response. Moderate TAS versus moderate endophthalmitis, and severe TAS versus severe endophthalmitis. Quite often in TAS, due to fibrin membrane formation, there is a pupillary block with iris bombi. Anterior segment OCT will be helpful in all such cases. In severe TAS, there is limbus to limbus corneal edema, which is more pronounced due to severe generalized endothelial chemical damage and cell loss. Severe damage to iris tissue leading to fixed mydriasis and thinning of the iris. And trabecular meshwork is damaged and almost completely coagulated, so the IOP is very high. Trabecular damage is often visible on gonioscopy. In severe TAS, intensive corticosteroid therapy is needed. There is no role of anterior chamber lavage. Pars plana vitrectomy is generally not needed. Many patients will need DSEC or DMEC, and most patients will need glaucoma tube shunt as well. Intravitreal or posterior subtenon tricort may be needed if the CME is significant. In the next video, we will try to understand the inferences of ESCRS endophthalmitis study. Thank you for your patient listening.